This is Dr. Chitra, your mentor at StudyMEDIC and StudyEFOG. And today in this video, we are going to see important points about connective tissue disorders. So let us begin. Coming to connective tissue disorders, these are common in women of reproductive age group. Most of them are autoimmune conditions. They might be pre-existing before the pregnancy, or some might manifest for the first time in pregnancy. Rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis have an increased incidence in the postpartum period. Now, why are we so worried about these connective tissue disorders? Because they can have a varied effect on the pregnancy. Now, this effect on the pregnancy, it depends on the type of disease, the disease activity and severity of symptoms. It also depends on the nature and severity of organ damage in the woman. What are the circulating autoantibodies, and what is the medical treatment needed during pregnancy? All this will affect the pregnancy. Now, before starting about the main points of these connective tissue disorders, we have to understand the changes in the immune response in pregnancy. We know that in pregnancy, there are high circulating levels of progesterone, estrogen, and cortisol. All of these have a negative immunomodulation, and they lead to immunosuppression. Also, there is a decrease in the NK cell activity, that is the natural killer cell activity. And the immune response, that is in the non-pregnant state, it is mediated to Th1, or it is a cell-mediated response. In pregnancy, there is a shift from Th1 to Th2 response. This Th2 response is antibody-mediated, or it is a humoral-mediated response. But remember, there is no change in T cell or B cell number or antibody production. Now, what happens in SLE? In women, those who have SLE, this normal conversion from Th1 to Th2 response in pregnancy, it doesn't happen. And that is why it leads to a pro-inflammatory cytokine phase. And there is blockade of complement inhibitors by antiphospholipid antibodies, which leads to recurrent pregnancy loss. There is increased placental complement deposition, and that leads to adverse pregnancy outcomes. Now, because there is no change in the immune response from Th1 to Th2, and since SLE is mediated through Th1, so that is why SLE can have more flares in pregnancy. Whereas what happens to rheumatoid arthritis? In rheumatoid arthritis, there is an exaggerated Th1 response, or rheumatoid arthritis is mediated through the Th1 response. But in pregnancy, what happens? The Th1 response, it shifts from Th1 to Th2. So that is why rheumatoid arthritis doesn't flare up in pregnancy. In the postpartum period, there can be an exaggeration, and this is due to resurgence of T cell mediated immunity. And it is said that breastfeeding makes this flare worse. It could be because of the presence of prolactin in the postpartum period. Salient points to remember about rheumatoid arthritis. Female to male ratio is 3:1. It is a chronic inflammatory disease affecting the synovial joints, but there are extra-articular features also. Which are these features? There could be fatigue, there is vasculitis, there could be subcutaneous nodules, anemia, it is because of the bone marrow suppression. Then you have pulmonary granulomas. There could be effusions, fibrosis, cardiac involvement, and amyloidosis. Women with rheumatoid arthritis may have secondary Sjogren's syndrome. So what is this? Secondary Sjogren's means it affects the exocrine and the lacrimal glands, leading to dryness of the eyes. Effect of rheumatoid arthritis on pregnancy. We already saw that there is an improvement, or there are no flares during pregnancy. So 50% of these women with rheumatoid arthritis, they improve in pregnancy. For some of them, the symptoms may worsen. Now, why do the symptoms worsen? Because women, they are afraid of the drugs. They are afraid of the disease-modifying anti-rheumatoid drugs, and they stop the drugs during pregnancy, and the worsening could be because of withdrawal of these drugs. For women, those who improve in pregnancy, the improvement begins in the first trimester. Okay. And there are exacerbations in the postpartum period. probably in the first 4 months in the postpartum period. And for some women, rheumatoid arthritis presents for the first time in the postpartum period after the first pregnancy. What is the effect on pregnancy? So, rheumatoid arthritis has fewer side effects than SLE. There could be an increased risk of preterm delivery and small babies. And for women, those who have anti-Ro antibodies, infants can have neonatal lupus. We are more scared of SLE. Let us see the important facts and how you are going to diagnose SLE. So, male to female ratio is 9:1. The incidence in women of childbearing age group is 1 in 500. Precipitating factors are puberty and pregnancy, and it is more seen in women of Afro-Caribbean and Asian origin. Now, there have been new criteria which have been laid down for diagnosis of SLE. So, there are some entry criteria. The entry criteria is that for a woman to be labeled as SLE, she should have anti-nuclear antibodies, and they should be present in a titer of more than or equal to 1 in 80 on Hep2 cells, or you should have an equivalent positive test. Now, if the woman is negative for ANA antibodies, please do not label her as having SLE. If ANA antibodies are present, then apply the additive criteria. So, which are these additive criteria? Now, remember, for the additive criteria, do not label it as SLE if there is a more likely explanation than SLE. And the occurrence of criteria, even on one occasion, that is enough to label the woman as SLE. So, for SLE, the woman requires to have at least one clinical criteria and more than or equal to 10 points. All the criteria need not occur simultaneously. Now, within each domain, the criteria that has the highest weightage, that is the one counted towards the total score. So, I want you to stop this video here and have a look and read the criteria. So, you have clinical domains and criteria, and then you have immunological domains and criteria, and the weightage is given. So, you will make a total of this. If it is more than or equal to 10, ANA antibodies are present, then the woman is labeled as having SLE. Now, what is the effect of SLE? What is the effect of pregnancy on SLE? We already saw that there is an increase in the flares during pregnancy and puerperium also. And these flares are more likely if the disease was active within 6 months of conception. The flares can be less in women, those who are taking hydroxychloroquine. Now, remember, in pregnancy, the flares can be difficult to diagnose because some of the symptoms that are seen in the flares, like hair loss, edema, erythema, fatigue, anemia, increased DSR, and musculoskeletal pain, these could also be normal features of pregnancy. The risk of renal flare is 30% and higher if lupus nephritis is not in remission or it is in partial remission at the time of conception. So, whenever a woman has a lupus flare, advise her that she should delay pregnancy for a period of 6 months, or there is a higher likelihood of having a renal flare in pregnancy. What is the effect on pregnancy? Okay. So, women, those who have anticardiolipin or lupus antibodies, or they have lupus nephritis or hypertension, or they have active disease, or they are presenting at the first time in pregnancy. For these women, there is an increased risk of miscarriage, fetal death, preeclampsia, preterm deliveries, and fetal growth restriction. The outcome for those who are affected by renal disease, if the disease, they are quiescent if it is lupus associated with fetal loss, preeclampsia, and fetal growth restriction if there is hypertension or proteinuria. Women, those who are in remission and do not have any other associated risk of pregnancy, For them, risk of pregnancy loss and preeclampsia is no higher than in the general population. So this is the effect on pregnancy. Now, it is very important to differentiate active renal lupus from preeclampsia in pregnancy, or you want to rule out whether this is a SLE flare. Remember, it is very difficult and sometimes they can superimpose because they have common signs and symptoms like hypertension, proteinuria, thrombocytopenia, and renal impairment. The only definitive investigation which can differentiate between a active renal lupus flare and preeclampsia is a renal biopsy, but as we know, renal biopsy is not undertaken in pregnancy. So how do you differentiate? Then there are some biochemical factors that you can see. So if there is hyperuricemia, if the LFTs are abnormal or placental growth factor is low, then this points more towards preeclampsia. But if there is a fall in the complement levels, so this differentiates it like preeclampsia from active lupus. And if the fall is more than 25%, then it suggests that it is active SLE. Because in SLE or in active lupus, there is a fall in complement levels. Other factors which could suggest that this is a flare of SLE, it could be the symptoms, or you will have a rise in dsDNA antibody titer, and in the urine, you can have RBCs or you can have cellular casts. Now, if it is really very difficult to differentiate between active renal lupus or preeclampsia, and if the gestational age is more than 28 weeks, it is appropriate to deliver the fetus if there are significant risks to the mother or to the fetus. What is the advantage? At 28 weeks, the pregnancy is salvageable or the fetus is viable. If the woman is delivered, it will cure the preeclampsia. And once the woman is no longer pregnant, you can go in and do a renal biopsy. Now, what is the management of these women? Those who have SLE and those who are pregnant. So management actually begins in the preconceptional period. You should advise these women that they should try to achieve a conception during remission. Women, those who have come to you for preconceptional counseling, you have to test for anti-Rho, anti-La antibodies, test for anti-phospholipid antibodies, anti-dsDNA, check her complement levels C3 and C4, look out for proteinuria, do renal function tests, and measure her blood pressure, because all these parameters are going to indicate what would be the effect of SLE on pregnancy. Now, women, those who are lupus nephritis or antiphospholipid antibodies are positive or they have vasculitis, treat these women with low-dose aspirin in pregnancy. These women, during pregnancy, they should be under care of a multidisciplinary team, and the team is responsible to monitor the disease activity and also monitor fetal growth. So how do you monitor fetal growth? You start with uterine artery Doppler at 24 to 28 weeks and umbilical artery Doppler from 24 weeks in fetuses, those who are at a high risk of fetal growth restriction. The lab features that have to be done frequently are a full blood count to look out for hemolysis, USNEs, that is urea and electrolytes, creatinine to know the renal function tests, liver function tests, anti-dsDNA and complement levels to know whether this is a SLE flare. Now, how do you look out for flares? So look out for arthralgia, pleuritic rash, skin rash, a rise in dsDNA antibody titers, or if there's presence of RBCs or casts in the urine, or a fall in complement levels. If there are flares, the drug of choice to manage the flares in pregnancy is steroids. For hypertension, the drugs of choice are methyl-dopa, labetalol, or nifedipine. Remember, do not use labetalol if there is history of bronchial asthma. Mode of delivery, it could either be a vaginal delivery or LSES for obstetric indications, and delivery should be in a consultant-led unit. Now, the next important factor that we are worried about in women with SLE is the effect on the fetus. So you have neonatal lupus syndromes. Out of this, most common is cutaneous lupus, and the most serious is congenital heart block. Fortunately, the two do not coexist. Now, mothers of affective offsprings, more than 90% of the mothers have anti-Ro antibodies and 50 to 70% have anti-La antibodies. The risk of congenital heart block is reduced in fetuses, the mothers of whom are on hydroxychloroquine. Coming to congenital heart block. So it can be diagnosed in utero. Remember, once you have congenital heart block, it is permanent. It can be fatal in about 15 to 20% of the fetuses. And how does it present? It manifests as fetal bradycardia at 18 to 28 weeks of pregnancy. The perinatal mortality is about 20% of them die, those who are affected in the early neonatal period. Amongst the survivors, 50 to 60% of them require pacemakers, and these pacemakers have to be lifelong. The next important condition is cutaneous lupus. Now, this manifests in the second week of life, and it follows exposure to sunlight, either natural sunlight or if the baby has jaundice and is being treated with phototherapy. The rash disappears spontaneously within 4 to 6 months, but you can have residual hypopigmentation or telangiectasia, and this may persist for up to 2 years, but the good thing is that it does not leave behind any scarring. It's important to know about the pharmacotherapy. You have a wide variety of drugs. You have simple drugs or the first-line drugs like simple analgesics and NSAIDs. Second-line drugs, also called the second-line drugs, you have immunosuppressants in the form of corticosteroids. And you have immunomodulators, also called as disease-modified anti-rheumatic drugs. Let us see simple analgesics. So you have paracetamol or codeine and opioid analgesics. Paracetamol, it suppresses central CNS pain mechanisms. It is safe in pregnancy as well as breastfeeding. Codeine and opioid analgesics, they bind to the opioid receptors in CNS and block ascending pain pathways. They are safe in pregnancy, they are not teratogenic, but do not use in breastfeeding. NSAIDs, in the first trimester, they can cause congenital heart block, heart defects. In the second trimester, they can lead to low birth weight. In the third trimester, they can cause oligohydramnios and early closure of ductus arteriosus. They can also cause necrotizing enterocolitis and intracranial hemorrhages, but they are safe during breastfeeding. So NSAIDs, avoid in the preconceptional period and first and third trimester. You can use them in the second trimester. Among immunosuppressants, corticosteroids. So the benefit of this is they are useful for acute control of the flare because of the rapid onset of action. But remember, if you are using them for a long time, you have to screen the mother for gestational diabetes. And during periods of stress, you have to give parenteral steroids like during labor. The safety, they can be used in all trimesters, but use prednisolone in a dose of less than 20 milligram per day and taper it to the minimum effective dose. For breastfeeding, it is better to breastfeed the baby before you give the dose of prednisolone or breastfeed 4 hours later after the woman has taken prednisolone. Let us have a look at the immunomodulators. So you have antimalarials. The commonest one that is used is hydroxychloroquine. It is given in a dose of 200 to 400 milligrams per day. Safe in pregnancy and breastfeeding, used in those who are anti-Ro or anti-La positive, and it is said that it helps in prevention of congenital heart block. Aminosalicylates, mesalazine or sulfasalazine, maximum dose of 3 grams per day. Whenever you are using mesalazine, give high dose of folic acid. Now they are safe in breastfeeding and in pregnancy. except like if you have a preterm baby, do not breastfeed, or babies those who have G6PD deficiency. Purine antagonists like azathioprine, the dose is 100 to 200 milligram per day. There is no adverse outcome in the baby, safe in pregnancy and breastfeeding. Cytotoxic drugs, so methotrexate, mycophenolate, mofetil, avoid in pregnancy because they are teratogenic. Cyclophosphamide, it can be used in the second and third trimester. Avoid in first trimester, also avoid in breastfeeding. Calcineurin inhibitors, cyclosporin and tacrolimus. They are safe in pregnancy and breastfeeding, but you have to monitor the woman for hypertension, preeclampsia, and GDM. Here also use the lowest effective dose. Now coming to biological agents. So you have anti-TNF alpha drugs and you have anti-lymphocyte monoclonal antibodies. TNF drugs are etanercept, adalimumab, infliximab. They have no adverse effects on the fetus. But remember, whenever you want to use these biological agents, you have to screen the mother for hepatitis B, hepatitis C, and HIV. Otherwise, these infections can flare up in pregnancy. Now, infliximab, it is advocated to stop at 20 weeks of pregnancy, adalimumab at 28 weeks, and etanercept at 32 weeks for women, those who are at a low risk of getting flares in pregnancy. For women, those who are at a high risk, you can continue these drugs throughout pregnancy, but remember that avoid live vaccination in these infants up to 6 months of age. Okay, so normally these drugs are safe in pregnancy. On the other hand, rituximab, it is said that it is a teratogenic. It has been found to be teratogenic. So normally it is advised to stop at conception. But if there is no other drug that is suitable for the woman, then explain the risk to the woman and this drug can be taken in pregnancy. But here also avoid live vaccination for 6 months after birth. It is safe in breastfeeding, but there is limited evidence for the safety. Now, next coming to the next connective tissue disorder or scleroderma. So it is rare. The incidence is 2.3 to 12 million per year. Female to male is 3:1 in childbearing age. There are two types, localized and systemic. There could be an associated syndrome called as CREST. So what is this? There is calcinosis, Raynaud's phenomenon, esophageal involvement, sclerodactyly, and telangiectasia. Effect of scleroderma, effect of pregnancy on the disease. Those who have localized cutaneous scleroderma, for them the prognosis is good. Raynaud's phenomenon, it improves in pregnancy, but esophagitis may worsen. And for those who have pulmonary fibrosis and pulmonary hypertension, these conditions, they worsen in the postpartum period. Effect of scleroderma on pregnancy. For those without systemic disease, the outcome is better in 70 to 80% of the women. There is an increased rate of miscarriage, preterm delivery, and those who have diffuse disease, they can have preeclampsia, fetal growth restriction, and perinatal mortality is increased. For these women, measurement of blood pressure and doing a venipuncture may be challenging. GA or general anesthesia, it can be complicated because endotracheal intubation is difficult and giving regional anesthesia is also difficult due to skin involvement. So what is the management? Management is mainly symptomatic. If the woman presents to you in early disease, advise her to delay pregnancy till the disease stabilizes. For women, those who have multiple involvement or there is severe organ involvement, advise them against a pregnancy. In the pre-pregnancy assessment, assess the lung function tests and also cardiac status by doing an echo. For women, those who have Raynaud's disease, you can help them with heated gloves or nifedipine. For the esophageal symptoms, you can put them on proton pump inhibitors. Remember, these women, it's a high-risk pregnancy, so there should be a multidisciplinary involvement. Important thing is avoid steroids for fetal lung maturation as you might precipitate a renal crisis. The next disease is Ehlers-Danlos syndrome. Now here, there is a defect in the collagen metabolism, and that leads to fragile skin and blood vessels. There is easy bruising, skin hyperelasticity, and joint hypermobility. There are 4 types. Type 1 and type 4 have the highest risk in pregnancy. In type 4, maternal mortality can be as high as 20 to 25%. Type 3, in which there is only joint hypermobility, is the commonest form. Now, effect of pregnancy on Ehlers-Danlos syndrome. In women, those who have type 4, there is an increased risk of aortic or visceral rupture. Those who have joint hypermobility, pregnancy may increase joint and back pain. Effect on pregnancy of the disease. So type 4 is associated with risk of uterine rupture, preterm delivery, and increased skin fragility and poor healing. Those who have joint hypermobility, they are at an increased risk of PROM and preterm cervical dilatation. They can have precipitate labor. They can have postpartum hemorrhage and skin fragility and poor healing. What is the management? So, if she has come to you without categorization of the disease, refer her to the geneticist so that you might know the type of Ehlers-Danlos syndrome. For those who have type 4, advise them against a pregnancy. If they present early in pregnancy, you can also offer termination of pregnancy. For vascular, a CS is advised at 34 weeks of pregnancy to reduce the risk of uterine or aortic rupture. It's always better to refer these women to an obstetric anesthetist for pain relief and labor, because for some of them, there is a resistance to the effect of local anesthetics. So these are the common diseases. Let us see a few questions that could be asked on this. Pause the slide, read the question, think over it, and then see the answer. So here you have a nulliparous woman, 16 weeks of gestation. She has painful and stiff joints, and she is positive for rheumatoid factor. So what is the likely diagnosis? It is rheumatoid disease. Okay. So whenever there is positive rheumatoid factor, it points to the diagnosis of rheumatoid disease rather than SLE or psoriatic arthritis, because these are seronegative arthritis. Okay. You have another woman who is 26 years old. She has been referred by her GP for pre-pregnancy counseling. She has mouth ulcers, joint pain, general fatigue, 3+ proteins on urine dipstick, blood shows thrombocytopenia, leukopenia. She was referred for further investigations and she has been found to be ANA positive. What is the likely diagnosis? Remember, ANA positive, it can be nothing else other than SLE. So it is systemic lupus erythematosus. Remember, ANA antibodies is the most important one. And then you should have the other clinical criteria and the points should be more than or equal to 10. You have a 24-year-old woman, 28 weeks into her first pregnancy. She has headache, high blood pressure, proteinuria. She comes back from an holiday from Japan and she reports that she had achy joints there. So which is this autoimmune condition which increases the chance of developing preeclampsia? Again, it is SLE. Okay. It is because of the renal, vascular, and placental involvement, rather than like in other connective tissue disorders, you do not have more of a vascular and renal involvement. It is more commonly seen in women, those who have SLE and those who have APLA. You have a couple who have been referred because the woman has been diagnosed with SLE. She has all the signs and symptoms. She has SLE with high titer of anti-nuclear factor, dsDNA antibodies. Her renal biopsy has shown stage 4 lupus nephritis. She is taking prednisolone, hydroxychloroquine, candicertan. ferrous sulfate, and azathioprine. So the question is asked is which of these medications have to be altered before or during pregnancy? Remember, it's candesartan because this is an angiotensin receptor blocker, which is contraindicated in pregnancy because given in pregnancy, it can impair renal function leading to oligohydramnios. So stop the drug prior to pregnancy and put her on an antihypertensive, which is more pregnancy friendly. Now you have another woman who was diagnosed with rheumatoid arthritis 6 months after birth of her first child. She was put on sulfasalazine. She is taking the drug and there is good control of her symptoms. She got pregnant the second time and she stopped the drug because she was scared. In pregnancy, she was fine. Now, in the postpartum, if she has a flare and she's not able to look after her newborn child, which is the drug of choice that you would want to start. Choices are diclofenac, hydroxychloroquine, paracetamol, prednisolone, or sulfasalazine. Remember, for control of a flare, the best drug to use is prednisolone because it has very good anti-inflammatory properties, quick onset of action, and when you start the steroids, by then you can start some other disease-modifying agents, such as you can again put her on sulfasalazine, or you can put her on hydroxychloroquine. But remember, the onset of these drugs, onset of action, it takes a longer time. So first start her on prednisolone and then gradually introduce the DMRDs. You have another woman diagnosed with SLE 5 years ago. She is in her 5th pregnancy. She is a heavy smoker, BMI of 40. She's not compliant with her medications. She has flares with joint and skin symptoms. At 28 weeks, she presents with hypertension. Blood pressure is 160 by 110. Urine analysis 2 plus protein. So now, which is the test that will help you differentiate between the lupus flare and preeclampsia? Remember, it is dsDNA antibody levels and complement levels. If the levels are raised, dsDNA levels are raised, complement levels are falling, it indicates that this is a lupus flare, it is not preeclampsia. Okay. Now you have a 27-year-old Paris woman referred at 8 weeks of gestation. She was diagnosed with SLE in her first pregnancy. First-born daughter has congenital heart block, required a pacemaker, which is the medication that should be given to this woman to prevent a congenital heart block in her newborn or in the fetus. So the drug of choice is hydroxychloroquine. Studies have shown that women, those who have anti-Rho, anti-La antibodies, for them, if they take hydroxychloroquine during pregnancy, the risk of the fetus getting a congenital heart block is less. Okay? And it is not a drug that is contraindicated in pregnancy. So you have a 37-year-old at 12 weeks of gestation, diagnosed with rheumatoid arthritis 10 years ago, very severe symptoms. She was put on etanercept and it changed her life. But during pregnancy, she is worried and she wants advice regarding this drug. So what advice will you give her? She can continue etanercept throughout pregnancy. But remember that you have to delay the live vaccine schedule for at least 6 months after the baby has been born. It is safe during pregnancy, also safe during breastfeeding. Now, let us see a few clinical syndromes, and what could be the likely diagnosis. So, in the options, you have Marfan syndrome, SLE, Ehlers-Danlos syndrome, psoriatic arthritis, rheumatoid arthritis, and pelvic girdle pain. Now, which is this condition which has a tendency to have less flares in pregnancy? Remember the immunology that we talked about? Less flares in pregnancy, it has to be rheumatoid arthritis. It goes in remission in pregnancy and it flares up in the postpartum period. Which drug has an increased incidence of preeclampsia in pregnancy? Remember, it is SL. Okay, it is because of the increased incidence of renal, vascular, and placental involvement in SLE, that these women have more incidence of preeclampsia rather than any other connective tissue disorders. Which condition has an increased risk of aortic dissection in pregnancy? It could either be Ehlers-Danlos syndrome or it could be Marfan's. Both of these options are correct, but if they specifically mention that Ehlers-Danlos type 4, then that is more associated with risk of aortic rupture rather than dissection in pregnancy. So aortic dissection, more commonly it is Marfan. If they say aortic rupture, then it will be Ehlers-Danlos syndrome. Okay. So these are the most important points and the type of questions that you could be having asked for connective tissue disorders. Thank you for watching the video. I hope you have found it helpful, and good luck for your exams.